Alright, today we're going to talk about education, organizations, the scope of practice, and evidence-based practice in speech-language pathology and audiology. This is chapter 13 and 15 of your textbook. So when we think about speech pathology and audiology, you really have to think about it as a science. So we're studying communication or hearing or language or swallowing from its anatomical and physiological basis. For speech science, we're looking at the formation and production of sounds and the perception and understanding of speech. So how the listener perceives that speech as well as how the producer produces that speech. From language science, we're looking at the larger and more abstract and organized system of verbal and nonverbal communication and the use of that in assessment and treatment. So we assess verbal and nonverbal communication differently and according to what population we're working with. And then from an audiology standpoint, we're looking at the hearing science, so the study of hearing and its anatomy and physiology, and the perception and understanding of its relation to communication. Because it's not just hearing sounds, it's also how we learn and acquire our language. So the first profession we're going to talk about is speech-language pathology, and it's a scientific profession concerned with the disorders of verbal and nonverbal communication, their assessment, and their treatment. Now, as a speech-language pathologist, it also includes not only speech and language, but swallowing disorders and the evaluation and the treatment. This is a newer field for our profession, probably within the past 10 to 20 years, and so it hasn't quite made it into the title, and it would make it a really long title, and so speech-language pathologist is the common term. You might also hear speech clinician, speech teacher, or speech therapist. In order to be a speech pathologist, you have to have a bachelor's degree. Now, it doesn't have to be in communication disorders, it can be in other areas, but you have to have those prerequisite courses before applying to a master's degree or pursuing the master's degree. That might mean that you do it before you apply. It might be that you do it as an extra year before you, or while you're enrolled in a master's degree. So after you get that bachelor's degree and you take all of the prerequisite courses, you take the GRE exam and apply to a graduate university, and then you pursue the master's degree. This is typically a 2 to 3 year program during which you're taking coursework as well as doing a clinical practicum, and that clinical practicum requires a certain amount of hours and that you treat every population in speech, language, and swallowing and that encompassing areas before graduating. And then before graduation or right after, you have to take the praxis exam, and this is a test specific to speech-language pathology. And it's similar to the GRE in that it's a standardized test, but it asks questions specific to the populations that you treat in clinical practice. You have to take the practice in order to get state licensure, and you have to have state licensure in any state that you're practicing in, as well as any state that you are treating patients in. So we have a newer thing now called telepractice, which means you can do practice over the computer or the telephone. And in order to do that, if the client is not in your state that you live in or that you're practicing in, you also have to be licensed in the state that they reside in. After you have the state licensure, you also apply for the Certificate of Clinical Competence in Speech Pathology. So this is CCC, SLP, which is what you typically see after a certified speech pathologist's name. The other informal name for it is the Cs. So you get your Cs by completing a clinical fellowship year, and it's called a year, but it can last up to 3 years, sometimes longer, depending on what state you're in. In Louisiana, your clinical fellowship year has to be done within 3 years. And that means that you're working under a clinically certified speech pathologist, and they're observing how you're doing therapy and what you're doing, and this ensures that you're providing our evidence-based practice. If you have any other questions or you need more information on the speech pathology certification and education, then you can click that link down there at the bottom. As far as audiology goes, it's a profession that looks at disorders of hearing and the rehabilitation of individuals with hearing impairments. So they look at the assessment and treatment of hearing disorders and oral rehabilitation. So their requirements are also the bachelor's degree in communication disorders. Again, it can be a non-background. You have to take the GRE exam. And it used to be a master's degree until 2012. Now it's a doctorate of audiology. It's a little bit different than speech-language pathology. So speech pathology is 2 years of coursework with clinical practicum. Audiology, or the AUD, is 3 years, 2 years of coursework, 1 year of clinical practicum while you're enrolled. So you're completing that CFY year during your graduate experience. For speech pathology, you complete that CF year after your graduate experience. You also have to have state licensure and that certificate of clinical competence. And again, if you have more questions or want more information, those standards are down there below for ASHA. As far as organizations go, the national organization is ASHA, so the American Speech, Language, and Hearing Association. They're the ones that give us our Cs. They're our overarching organization that tells us who we can see and what we can do. There's also the Council on Academic Accreditation, or the CAA, and that's the division of ASHA, and they work for academic program accreditation. So anytime you hear about accreditation, it really goes back to the CAA, and you want to go to a university that has accreditation. Otherwise, you can't obtain the state licensure or the Cs. At the state level, every state has their own board. For Louisiana, it's LABESPA, so the Board of Examiners, and they give us our state license. And they also do Department of Education certification for speech therapists in the school system. So for the ASHA scope of practice, hopefully you've read it by now. You might be wondering kind of why we have a scope of practice. Now, when you think about a scope of practice, it's really thinking about the areas that we can treat, who we can see, and what we can do. So as a speech pathologist in the hospital, I can't just go in and, start an IV on somebody because it's not in my scope of practice. At the same time, a nurse can't walk into my room and start giving speech therapy treatment. So it really helps us define who we are and what we can do. So it identifies the areas of professional practice for SLPs and audiologists. It differentiates speech and audiologists from other areas. So thinking about our physical therapists or our occupational therapists, all of us can touch on swallowing, but we touch on swallowing in different ways. And then it informs others about the services provided by speech pathologists or audiologists. So if someone wants to know, why am I seeing a speech therapist? Or if a doctor wants to know, why is that speech therapist seeing this patient? They can look that up and say, oh, okay, it falls into their scope of practice. It also supports the provision of high quality and evidence-based services. So by having that scope of practice, we can see, all right, if I need to treat this specific population, how do I need to treat it, and how do I treat it efficiently and correctly? And then it supports the conduction and sharing of research. So if I'm doing research under the scope of practice, I've learned similar information to other speech therapists, and I can share the information that I acquire through my research with other speech therapists without starting from scratch. And then it guides our educational preparation and professional development. So this goes back to our accreditation. We have to be sure that we're having classes and coursework specific to our scope of practice and covering all of the areas of our scope of practice in order to ensure that we have well-rounded speech therapists and audiologists. So we'll talk about a little bit later the ASHA Big 10, which is now the ASHA Big 12. So we used to have coursework really just in speech and language. And then over time it's acquired other areas, including feeding and swallowing, that weren't included before, because we've kind of dipped into these areas and our overarching organizations have said this is something that we need to define and work on. So when we're talking about the different roles and service delivery areas for speech pathology, we're looking at language, cognition, fluency, speech sound production, resonance, voice, feeding and swallowing, auditory rehabilitation and habilitation, as well as other elective services. So again, we started out as speech pathologists, and then we became speech language pathologists, and now we're really kind of an all-encompassing, which is why we start to get more specialized in what we do. So the different domains we look at are our professional practice domains, as well as our service delivery domains. So for professional practice, these are the areas that we do as professionals, kind of within the community and within each other. So we can do advocacy and outreach for our profession as well as for our patients. So if you think about ALS, it's something that wasn't quite familiar many years ago until there was the Ice Bucket Challenge. That's advocacy for that population. If we're talking about a speech pathologist, we can do advocacy similar to that for our populations so that there's more awareness of what we're treating and more acceptance of what people within our community are dealing with. We also supervise. So as a clinical director or a clinical instructor or as a CF supervisor, you're supervising younger clinicians to withhold the standards of our field. We also do education, and that can be either through community education, professional education, or communication education through our CF fellowships. We do administration and leadership. So ASHA has speech pathologists within the organization that work and lead us in what we need to do. And we also conduct research. That doesn't have to be big scale research that makes it into journals, but it can be research within our own clinics to say, I'm doing this clinical practice, I hope it's helping, but I'm not quite sure. So you do a quick little look at what you're doing in a methodical way, and you can see, oh, I'm making progress, this is a good type of treatment to use in this population, or no, it's not quite. And then for service delivery domains, we look at collaboration. This means that we're working with people in other fields as well as people within our field. So as a speech pathologist in a hospital setting, but also even more specialized, I look at swallowing and voice. That doesn't mean that I treat people that don't have anything else going on with them. It means that I'm going to focus on the swallowing and voice aspect of their disorder, and if they have an aphasia or a language disorder along with it, I can collaborate with another speech therapist that specializes in that area to ensure that they're getting their needs. We also counsel our family members and our patients in what they're going through. And of course, if it's too much or beyond our scope of practice, we refer to a counselor or a psychologist. We also do prevention and wellness. So if we talk about aphasia, it usually happens after a stroke. And so we can talk about prevention of a stroke. The same thing with a traumatic brain injury. We can talk about how to wear helmets or buckle up when you're in the car. Our biggest area of our field is screening, assessment, and treatment. So we screen for those that might have a communication or swallowing disorder. We assess them, and then we treat them. And we can also use different modalities, technology, and instrumentation in order to achieve that treatment goal. And we work within the population, within the systems, to ensure that we're getting all of the service delivery met. So different practice settings that speech pathologists can work in. There's a lot of them. This is not all-encompassing, and it kind of changes every day. One of the most interesting ones is kind of the corporate and industrial settings, or even the home health. So home health means that you're going into a person's home and providing services. For the corporate and industrial settings, you may be going to a business and working on presentations in ways that communicate with everyone on the team, to speak clearly, to include very clean slides, to include information that's helpful to those workers. It can also be accent modification for those from other countries or speaking other languages. As far as correctional institutions go, we know that there is a high incidence of prisoners with language disorders, and so we can go into correctional institutions and work on that. The different etiologies that we can work with is really doesn't even touch on this list. It's a very long list and it continues to grow. It just depends on the different disorders and how they can affect communication and swallowing. These are some of the ones that we'll talk about in this class this semester, or we'll just briefly touch on, but there's definitely more than that. As far as audiologists go, their scope of practice provides comprehensive diagnostic and treatment and rehabilitative services for auditory, vestibular, and related impairments. So auditory is hearing, vestibular is balance. They also work for prevention of hearing loss and protection of hearing function. So think about somebody who's in the Army and going into an area of war and they're exposed to bombing. That is an area that can damage hearing just because of the sound of the bomb. And so they work on hearing aids or devices to protect hearing and reduce that damage to the hearing system. They also select, fit, and dispense hearing aids and other hearing assistive devices. So those can be microphones with speakers in the classroom as well as cochlear implants. They do functional diagnosis of vestibular disorders and management of balance rehabilitation. They also identify populations and individuals at risk for developing speech-language impairments. So the hard of hearing or the deaf are at risk for speech-language impairments. And they get those people in touch with speech-language pathologists, so it's a way that we collaborate. They also do skills training and consultation concerning the environmental modifications. So in the school setting, they may go into a classroom that has brick walls or cement walls, and there's a lot of echoing, and it's not very good for a student's ability to hear what's going on in the lecture, particularly for those that are hard of hearing or deaf. And so they may go in and say, you need to put some pads in here to absorb some of that sound. And they also provide academic education to those that are coming into the master's program. Different practice settings for audiology include schools, hospitals or clinics, the physician's office, research facilities, and other healthcare facilities. So again, just like speech pathology, it's really all-encompassing. There's a lot of areas that they can work in. When we talk about collaboration, it's not just about collaboration of speech pathologists to another speech pathologist or speech pathologist to audiologists. It's also within the community and the service team for a patient. So in my clinic, I work in a voice clinic with an ear, nose, and throat doctor. And I also work with head and neck surgeons and radiation oncologists, and we work on the outcomes for swallowing in head and neck cancer patients, whether they're having a surgery or radiation or chemotherapy. We also work with voice disorders for patients who have injury to their vocal folds. We can work with a psychologist or a psychiatrist, particularly for those that have cancer and are having trouble dealing with either the cancer treatment or the swallowing effects long term. We can work with physical therapists, occupational therapists, any type of therapeutic recreation, different nursing staff, and of course the family, parents, and caregivers are always a part of the multidisciplinary team. And again, this isn't an all-encompassing list. You're going to communicate with many different people within the community. When it goes to counseling, we're looking at the interactions related to the emotional reactions, thoughts, feelings, and behaviors that result from living with a communication disorder or a feeding and swallowing disorder. So we're looking at empowering, educating, providing support, providing skills, and discussing, evaluating, and addressing negative emotions and thoughts. But of course, if it goes beyond what we can handle, we refer it to a counselor. And sometimes we have to do that whether it relates to a communication disorder or not. So for example, I had a patient a few years ago that had trouble with her voice, but she was also in a bad relationship, and so we had to refer to a counselor so that she could talk about what was going on in her relationship because it also influenced her voice. Now when we look at how we provide our treatment, we have to look at the different ways that we're doing it. So we talked about blogs earlier and how the internet kind of gives us this really great way to share information and get information from people with similar experiences. The problem is it creates a lot of noise, and we have to be able to differentiate if it's good noise or bad noise. Now, when we're looking at either children or adults, we have to be able to have evidence to back up our statements, which means that if we are providing services and we say that they're getting better, we have to have the evidence that shows that they're getting better. So we have to track the progress that our patients make. We also have to counsel patients to improve their understanding of their problem. So we can't just say, hey, your kid has a language disorder. We have to say why it's there and what we're going to do about it and why we've chosen our approach. And then we have to record those clients' responses. So that goes back to the evidence to back up our statements. And when we write our treatment goals and our procedures, we have to write them in objective terms, which means that we can't just say, oh, Johnny's going to get better at his speech. We really have to say, with these cues and this much time, for this specific goal, this patient's going to achieve this outcome. So what that all means is that we do evidence-based practice. So it tells us why we do what we do, and we justify our treatment plan. So when we talk about evidence-based treatment, we're looking at the diagnosis as well as the treatment. Now, when we think about diagnosis, it's not just a cookie cutter, okay, this is what you have. You know, if someone comes in and they say, when I take a pill, it gets stuck in my throat, I go, yep, you have a swallowing disorder. That's not really how it works. I have to get a background history on a patient, which means that if they have something else going on in their history, it can influence their swallowing. So have they had a surgery, or have they had other trouble with their voice, or trouble with other foods, or has this been very slow to happen, or did it happen all of a sudden? And then I have to administer a test. Now, in swallowing, there's really only 2 tests that we can do, but in language and articulation, we have to use culturally and linguistically appropriate standardized assessment protocols. So that doesn't mean that I walk up and say, hey, here's a picture of a dog, tell me what it is, and they don't get it. I have to give it to them either in their language or in a culturally sensitive way, and it has to be standardized. And that tells us that compared to a big group of people, this is how this particular person is performing. And then we determine the skills in a naturalistic setting or context. So we use that standardized protocol to get our baseline, and then we also look at, okay, instead of breaking down the different parts of our approach, then we can look at how they perform in their everyday life. And then we diagnose. So it really takes a lot to get up to the diagnosing portion of the assessment. And after we diagnose, we have to document everything that we do. So that includes all of our standardized assessment as well as the assessment in the naturalistic setting. And then we develop a treatment plan and our recommendations, which includes a plan for dismissal. So that means that I know where this patient is now. I'm projecting where I want the patient to be, and once they meet that projection, it's time for them to go. Or once we get there, this is what we need to do further. For treatment, we're trying to establish a new skill or an ability, and it might remediate or restore an impaired skill or ability. So if we're establishing a new skill, it might be a language delay in a child. If we're remediating or restoring a skill, then it might be an adult after a stroke. And then we design and implement and document that delivery of service in accordance with best available practice. So we want to make sure that it has research to back it up, it has clinical practice to back it up, and it makes sense according to that patient, and we're doing things within our scope of practice. And we integrate the highest quality of evidence-based practice, and we'll talk about what exactly evidence-based practice is in just a minute. Again, we provide culturally and linguistically appropriate services, and then we integrate the personal treatment material or goals into treatment. So it's not just about what I want the patient to do, it's also what the patient wants. And then we deliver the appropriate frequency and intensity of treatment using that best available practice. So if we're delivering treatment once a week, every other month, it's not going to help very much. It's like attending class once a month and going, okay, at the end of this, you're going to have a bachelor's degree after a year. It doesn't really work. So we have to make sure that we're giving the right frequency and intensity to make adequate progress. And then we engage in treatment activities within our scope of practice. And again, that integrates that personal material. And we collaborate with other professionals and use our treatment data to guide decisions and determine effectiveness of services. The ultimate goal of therapy is to improve an individual's functional outcomes. So it's not just about can they answer a question on a worksheet or can they tell me what a picture is. We're really trying to improve people's lives and their ability to function within their roles. So evidence-based practice is a continuous and dynamic integration of evolving clinical expertise and external evidence into day-to-day practice. So we include not only the current best evidence, which means our research articles that we have to read, but as well as our clinical expertise and our client and patient values. Sometimes our clinical expertise is just a little bit ahead of our current best evidence, and vice versa. We might be doing things that are outdated because it works for us in our clinical practice, but there might be things in the research that work better. And so we have to stay on top of that. At the same time, if there's something that our clinical practice supports and our research supports, we have to take into consideration the client and patient values. So if they say, I don't really want to focus on that, or that's not something that I'm interested in, we have to find a new approach. Ultimately, evidence-based practice means that as my field's knowledge changes, my practice changes. So just because I know 3 exercises for swallowing doesn't mean that I do those 3 exercises forever. I have to continuously learn what works for my patients and what works in my clinical practice, because we can find things that work better or that are specific to certain people. When we're framing our clinical question, this is how we are structuring our clinical practice. So if I work in a setting where I see toddlers with expressive vocabulary delays, and I'm looking at the different types of treatment, this is kind of like a research question. I want to know, comparing this type of treatment to this type of treatment, what works better? Because not everything is cookie cutter and picture perfect. So in order to form that question, we can use the PICO or the PICO, which gives us the type of patient or problem we're looking at, the intervention that we want to use, the comparison or the contrast, or the outcome. So for instance, in this case, we have in toddlers with expressive vocabulary delays, does focused stimulation lead to significantly greater vocabulary gains than no treatment? So our patient or our population is toddlers with expressive vocabulary delays. Our intervention is our focused stimulation, so the type of treatment we're trying to provide, and then we're comparing that treatment to no treatment at all. If I don't give any treatment to this kid, is it going to make better vocabulary gains than someone with this focused stimulation? And the outcome is our vocabulary gains. When you're trying to provide evidence-based practice, it's kind of similar to being in school. You have to find research articles, you have to work through your clinical practice and gain that experience. When you're in school, you kind of have an advantage of using the library databases to find the research articles, and so we'll just focus on that today. There is an LSU library research guide specific to COMD 2081, and so that link is there at the top. It tells you how to find evidence or reliable evidence versus blogs and things like that. There's also a page for how to use common library databases, like the Discover and EBSCO and things like that. Now, the two that will help you not only now but in the future are the ASHA evidence-based evidence maps and the ASHA practice portal. We'll get more familiar with these as you go through the semester, but it's something to take note of for your future classes when you're thinking about your projects that you'll have to write papers on or make presentations. These are a good place to start if you're not quite familiar with what you have to work with. Some additional resources are some of the things we talked about in class on Thursday. And then I also included here at the top the Planning Your Education in ComD. They also have an information page for students and a way to learn about the ComD professions. I encourage all of you to observe speech pathologists in their practice settings, either through your job or volunteering or just asking a speech pathologist. You can contact speech pathologists in the area and audiologists as well and ask if you can come and observe for a couple of days. Most of them are happy to have students come and observe them. It's really the best way to see what we do in our field and understand it. Watching YouTube videos helps, but it's not really perfect because they show you the best situation. So getting down and dirty with what we actually do is really helpful. The stipulation with that is that some places do require a lot of hoops to jump through to be able to observe, but it's still worth pursuing. When I was in undergrad, I observed at 2 hospital settings. I had to fill out some paperwork and do a background check, but it was well worth it, and it got me to kind of work through what I'm interested in and then identify a very specific field that I'm interested in, which is how I got into feeding and swallowing. Now, as the LSU ComD webpage goes, there's the research tab at the top of the page that gives the links for the ComD labs. Some of them are looking for volunteers to work in the lab, or they're looking for research participants. Either way, it's good to contact those faculty members to see if they're looking for volunteers. And again, it's really recommended that you do this here at the beginning, or if you wait, know that it's going to be next semester probably before you get to volunteer with them. I know that Dr. Kim's lab is looking for a research volunteer, so if you're looking for, a volunteer for the lab, if you're looking for volunteer experience, you can email her, or you can email Austin Thompson, which is her PhD student. The other links are for the curriculum, which we went through on Thursday, and then the contact information for Rhonda is on there, and then the contact information for Monica Holman, the advisor. Alright, on this page we have the LSU ComD website. You can just Google LSU ComD. From here you can go down to why you want to be a ComD student, and it'll give you a quick little PowerPoint. Up here at the top we have the information for curriculum, advising with Monica Holman, or you have the undergraduate course descriptions. For the master's program you can also look at the requirements for admissions. And over here on research, these are different research labs available at LSU and run by the professors here. Each one has different information about what they do in their labs and if they're seeking participants for their research or someone to come and work in the lab.